Hi, I'm Dr. Elizabeth Batista. I'm a family doctor here at in Grand Falls, Windsor, since 2001. I'm also an NRP instructor. Today I'm going to be talking about neonatal resuscitation. The objectives of today's talk are to learn about resuscitation of the newborn infant, to understand some of the steps in receiving a newborn baby, and recognize when resuscitation might be required, to understand the response required for apnea beyond 30 seconds, and fetal heart rate less than 60 beats per minute. Also to practice PPV and chest compressions on a model. So why is it important to learn about neonatal resuscitation? Well, 10% of newborns will require some assistance to begin breathing at birth. Fewer than 1% of these will need extensive resuscitation, and knowledge of initial resuscitative steps is vital, even to providers that are not providing regular intrapartum care. It's important in neonatal resuscitation, as in any resuscitation, that there are ABCs. So airway, breathing, and circulation. As far as the airways go, you position the baby in a sniffing position, suction out any fluids that might be, and then usually stimulating is just drying the baby off with a towel. Always important to remove the wet towel and have a dry one underneath, because the babies will cool down otherwise. And circulation to assess heart rate and oxygenation. So heart rate is typically done with the stethoscope or feeling the cord. And oxygenation, just looking at the baby and what is the color. In all deliveries, it's important to assess baby's risk of requiring resuscitation and to provide warmth, to position the airway and clear required, dry and stimulate the baby to breathe. In terms of deciding whether baby might be at risk for needing resuscitation, you want to find out from the mom about how far along she is. Is she term? Is she preterm? And then once the baby is delivered, is the baby actively, spontaneously breathing? Is the baby crying? What is the baby's color? When it comes to listening for the heartbeat and what numbers are important to remember is if the heartbeat is less than 60, generally additional resuscitative steps are required, and it will be important to call for assistance. If you're there by yourself, to call additional people in. And also, if the heart rate is greater than 100, usually this indicates that resuscitative steps may be stopped. So if the heart rate increases from less than 60 to greater than 100, you can generally stop as long as the baby is breathing. When it comes to apnea in the newborn, the primary actions in neonatal resuscitation are aimed at ventilating the baby's lungs. Once this has been accomplished, the heart rate, blood pressure, and pulmonary blood flow would improve spontaneously. Primary apnea will respond to stimulation, such as drying or slapping the baby's feet. So initially, when you were drying the baby and maybe giving a slight tap, this should actually bring around the breathing, the initial respiratory efforts of the baby. If this does not, if the baby does not start breathing with these mild efforts of drying, stimulating, then carrying on and continuing to do further efforts like being rougher with the baby, really drying quite hard, it's really probably not going to work. After 30 seconds of stimulating your baby and if the baby has not begun breathing spontaneously at this point, you have secondary apnea. And it's really important to carry on with PPV then. Positive pressure ventilation. In terms of PPV, the apparatus we're most familiar with is the self-inflating bag. So if the mask is not on, you just make sure the mask is on nice and tight, that there's a good seal. And you do this to make sure the pop-off valve comes up. You position the mask over the baby's nose and mouth and have the head in a sniffing position and breathe 2, 3, breathe 2, 3. Breathe 2, 3. It's important that you don't press too hard on the bag, as that will put the baby at risk of having a pneumothorax. It's really a soft, gentle squeeze, enough to see the rise and fall of the chest. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. You're going to be doing at least 30 seconds of effective positive pressure ventilation, and then assess to see if your baby is breathing, if your baby is crying, what your tone is like, and what the heart rate is like. Currently, when you're doing PPV, you're going to be using room air, so the oxygen is not on. The oxygen levels of a newborn baby are naturally lower at birth. In the first minute of life, they'll be between 60 and 65%, and it takes about 10 minutes for the oxygenation to get up to 95%. So it's natural initially for the babies to have a lower oxygen. It's important not to hyperoxygenate the baby. If you have an oxygen saturation probe at your site, you could at this point put an oxygen saturation probe on the right wrist of the baby to monitor the oxygen level appropriately. So if, when we say 30 seconds of positive pressure ventilation, what do we mean by that, and what are the steps that you can take to correct if you're not getting a good rise and fall of the chest, or if your baby's not breathing, or if the heart rate is not coming up? One is to make sure the mask is appropriately applied. So is the mask a good tight fit? It comes in a couple of different sizes, so you could change the size. It might be leaking out around the baby's cheek. You may need to put a little roll underneath the baby's shoulders. So you could roll up a towel and put underneath the shoulders, and this will automatically put the baby's head in more of a sniffing position. So you can try that. You reposition the airway, that's the second one. Suction the baby's mouth and nose again. If you have wall suction, you could do that by wall suctioning. If not, your bulb syringe will work well as well. And then the next thing would be to increase the pressure. So if you were going, you could do a little bit more pressure to see if that helps a little bit more. And if all of this is not working, lastly, you could consider a different airway, such as endotracheal intubation or laryngeal mask airway. If you've been doing effective PPV for 30 seconds and you're still not getting the rise in heart rate, because heart rate is still less than 60, chest compressions will be the next step that you would consider. Also, you could consider intubation to someone there that was trained in doing that. Otherwise, carrying on with the PPV would be okay. You obviously need a second person to do this, because you'll need one person to be looking after the ventilation, the PPV, and then another person to do the chest compressions. Once you begin chest compressions, it is important to increase your oxygen to 100%. So before now, we've been on room air, and we're going to be increasing the oxygen to 100%. To do effective chest compressions, the thumb technique is preferred. And with the thumb technique, what you're going to be doing is going across the nipple line, feeling the lower edge of the ribs of the baby. You're going to feel the xiphoid process there. Just above that, with your thumbs flexed, compress. And you're going to be trying to compress about 1/3 the AP diameter of the chest. And the rhythm is 1 and 2 and 3, and then the person that's doing the PPV would do breathe. So 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe. When you're doing this, you do it for 45 to 60 seconds, because it's been shown that you really need about that much time of coordinated chest compressions for the oxygenation to improve and the baby to start responding. After 45 to 60 seconds, you could get someone then to check the heart rate and see if the heart rate is greater than 60. If it is so, you can continue on with the PPV until the baby starts responding and discontinue the chest compressions. If your hands are really small, or if the baby is quite large, you can do the 2-finger approach, but the thumb technique is preferred. This has been a very brief overview of a neonatal resuscitation and general first steps that you could do. To learn more information, it would be a great idea to actually obtain certification in NRP.